Hello, I'm Doug Musio. This is the second of a two-part conversation on healthcare. And last week's show, which you can stream on CUNY TV's website, we looked at the bill that passed the House on November 8th, what it did and what it didn't do. What are the problems of the delivery and finance of healthcare in the United States? I'd like to welcome back my two colleagues from the School of Public Affairs at Baruch College. Shoshanna Sofaer is the Robert Luciano Chair of Healthcare Policy at Baruch. She is an internationally recognized expert in healthcare measurement and improvement, in the development of materials and interventions for healthcare consumers, and in the assessment of medical education. Professor Sofaer was honored last year by being named the Lorraine and Ralph Lubin Distinguished Visiting Professor at the Weill Cornell Medical College. Jonathan Engel is a professor and associate dean at the School of Public Affairs. He's recently published a book, American Therapy, The Rise of Psychotherapy in the United States, which has been widely praised and has stimulated much debate. He has authored 3 other books on the historical evolution of health and social welfare policy in the United States, and is now preparing a book manuscript on healthcare policy in the United States. Welcome back, folks. We sort of concluded last week with a discussion of financing, but we didn't quite conclude it. Shoshanna, how do you pay for a $1 trillion+ medical program?
Okay, let me back up a minute and make a point about $1 trillion.
Go
Okay?
ahead.
Sounds like a lot of money.
It sounds like a lot of money, and it is a lot of money. Okay,
Not even Mike Bloomberg has that much money.
that's probably true. So we spend at this point over $2 trillion a year on medical care in the United States. So let's say we're now spending $2.3 trillion. I think it's actually more than that. If we add $1 trillion over 10 years, what that really means is we're going up from spending $2.3 trillion to $2.4 trillion. So when you put it in that context, it's a lot of money, but it isn't as much as it looks like at the beginning.
Yeah, but that's still $100 billion. I mean, that's
still
still a lot of zeros.
Although let me quickly rush in. What we don't know actually
But
is
what your point is, relatively, the increase
it's a small
isn't
piece.
that dramatic.
And it may even be less than that, Doug, because right now we're providing a fair amount of health care gratis.
Right.
And essentially that care is not being accounted for in the way we really measure our health care. It's quite possible that we're already spending a lot of this money, that we're not accounting for it. It's not showing up in GDP because it's pro bono work, and that this will simply now be accounted for.
Okay.
So let's go back to how we pay for this.
Go.
And that's always going to be where the rubber hits the road and squeaks, okay?
Forget it.
Forget it. So one of the things that has been controversial here was paying for it through a variety of different money-saving activities elsewhere.
Right.
Okay. Now, the golden apple that everybody wants to reach for is that this bill would actually change the cost curve, as we call it,
Right.
bend the cost curve, so that we'd actually save money. That is largely a lovely fantasy, but it isn't going to really happen until we do a lot more fundamental things to change the incentives in the healthcare system, and this bill doesn't do that. As Jonathan pointed out, it basically ossifies, keeps in place a lot of that stuff. So we've gone hunting for where to get the money, and there is money apparently available in the Medicare program. For example, we currently pay the Medicare HMOs on a per-person basis more money than the fee-for-service Medicare system
Okay, so
spends.
you can save there. How much do you save altogether?
You save a few $100 billion there a year.
Hey,
so
come on.
it's not so
It's
bad.
not trivial.
Where
It's
else
not
do you get
trivial.
money?
Well, that's where some of the argument is between the Senate bill and the House bill. So people want to tax what are called Cadillac health plans.
That's in the Senate.
That's in the Senate.
Not in the House.
They're not doing that in the House.
They're taxing upper income people
They're
in the
taxing
house.
over a million
$1 million
people, with over a
dollars.
million in people who file jointly, over 500,000.
For
Point,
singles.
so it's 5.4% excise tax on every dollar over a million.
Okay, so we have different financing. Do we have any idea what's going to come out of a conference committee? No. So forget that.
No.
We don't know how
Really
it's going to
don't.
get
And
paid for.
I should say, I'm actually very skeptical about this tax and the Cadillac plans. I mean, for example,
I am
first
too.
of all, not that many people have Cadillac plans. Second of all, once you start taxing them, a fair number of people are going to walk away from the Cadillac plans. So, to me, the numbers that I'm seeing coming out of the CBO just don't ring right about the potential to really gain
Now,
income.
here's
out of
the
that.
issue about the public plan.
Go ahead.
Long term, the one advantage of the public plan
Explain
that-
what you mean by the
pub-
public plan.
Okay. In the House bill, there is a national public plan that would mean that there's Medicare now, there would be another nationally operated health insurance plan for people under the age of 65.
65, okay.
Owned by the federal government.
Owned by the
Right.
federal government, run by the federal government.
Right.
This plan is going to be able to charge lower premiums than private plans for a number of reasons. Their administrative costs are going to be lower.
And there's evidence for this.
Oh, yeah.
I mean,
Well, I mean-
internationally,
Yeah,
as well
Medicare
as
is actually
locally.
very low
Medicare
administrative
is
costs.
very, very low
like
administrative
2%
costs.
compared to like 13%.
13%, right. And then the other issue is they're not going to make a profit, right?
Right.
So whatever the profit is that the private plans are making,
Comes
the public
back.
plan is not
Right.
going to be making. But then the real issue is the public plan going to be able to and going to pay providers at lower reimbursement levels across the board? The Medicare plan does. The Medicaid plan really lowballs it with the providers, and that causes a lot of problems. So one of the compromises in the House bill was that they weren't going to go with Medicare reimbursement rates, but rather a negotiated rate.
Okay, now wait a second. Jonathan, your argument is that the docs and the other stakeholders in this game are motivated exclusively, primarily, if not exclusively, by naked economic self-interest, if I may phrase it
think
so
he said
broadly.
that.
Well, it's close.
Oh, whatever.
He'll take it.
There's a lot of self-interest.
Now, does the change that Shoshanna suggests, does that run in the face of that? Is that where it can falter?
Okay. So, right, there is what I think you said it in the last show. Do we have the opportunity to really change medical culture? And right now I'm skeptical, but we'll get
Okay,
into that.
go ahead.
Let's talk about this public plan for a second, though,
Go
and
ahead.
talk about how much pressure it's going to exert on the system. There are some people, I would call them on kind of the paranoid end of the spectrum, who say this seemingly innocuous public plan is really just a first step in moving us to socialized medicine. That before
This
you
is
know
the critic of the right.
Before you know
Republican
it, this public plan,
congressman.
because they have the cost advantage, because there's no profit center, ultimately will force all the other plans out. I want to start by saying I actually really don't think that's going to happen. If you
No,
look
neither do I.
at most of Western Europe, people seem to think that Western Europe has socialized medicine. Actually, what most of Western Europe has, besides the UK, is exactly what we have, a series of private, both for-profit and non-profit health insurance companies coupled with a public option.
Right.
And in none of these countries, Germany, Japan, France, Austria, has the public option forced out the private plans. Second of all, I would say, just to pull away from healthcare for a second, take a look at our education system. We have private universities, we have public universities. The public universities are cheaper. They're clearly cheaper. Would anyone suggest that over the last 200 years, public universities have driven private universities out of business? No. There seems to be enough of a diversified consumer base and a demand base that can support both. There are people who want the lower price and the lower level of service and student support that you tend to get in a public university. There are people who are willing to pay the premium for a private university. I think we're going to see the same thing with health insurance.
Why not a single-payer, government-run plan? One of my readings from the two professors dealt with the experience internationally, whether it's Britain, New Zealand, and Cuba, which is really close to socialized medicine, to what you mentioned earlier, Germany, the Netherlands, etc., that have a mix.
Let me pull aside two things there. First of all, Cuba and the UK are actually in a somewhat different category than Canada, Australia, New Zealand.
Go ahead.
Canada, Australia, New Zealand have a single payer. That is, there's one health insurance company, and that health insurance company is owned by the government. Although actually in Canada, it's actually various ones owned by the provinces, but let's call it one. That's a single payer.
Okay.
Cuba and the UK actually have socialized medicine, which is to say that the doctors and the hospitals are owned by the government.
Yes.
That's not true
Yes,
in Canada
okay,
and Australia.
okay,
So there's,
okay.
there's actually a very clear distinction. Nobody is talking about Cuba and the UK here. Nobody is talking about nationalizing our hospitals, nationalizing physician practice. Many people
So this
talk
is a
about this.
political and ideological weapon.
That's
the
right.
term socialized.
That's right. And I
medicine.
don't
always has
And
been.
it's no. As a political science, I understand that, but it seems to be effective in terms of certainly in terms of energizing the opposition.
Well, yes,
and in fact,
because
when you
it's
look,
against the American way. It's not. It does not support essentially a capitalistic, market-based health insurance situation. There are a lot of people who would probably financially benefit from a single-payer system who don't want to go there for really purely ideological reasons. Now, there are advantages and disadvantages to a single-payer system. I have a lot of close friends who are big supporters of single-payer. I do not happen to be such a supporter. Part of the reason for that is because, as I put it, would you really have wanted George Bush to be in charge of the entire health insurance system for the United States? And my answer to that is no. Okay, so I am a little bit nervous given our government and the structure of our polity. I'm very nervous about there being just a single payer, okay? But the major reason why I think we don't have single payer is that a lot of people who think it might be a good idea just don't think it's politically feasible.
Right.
So they don't want to waste their time on it.
Okay. I mean, that's a perfect
That's where
rational explanation. Okay.
I think Rahm Emanuel had a great quote yesterday. He said, "I'm not looking to get a bill through the Brookings Institution Board of Advisors. I'm looking to get a bill through Congress."
Right, and it is the making of sausage that makes Congress what it is. Okay, why do we spend so much more money per capita than anybody else and get clearly inferior results on a broad range of measures? What is this perverse consequence? Why? Explain
okay.
this to
Again,
me.
I'm going to go back to what I said before, is that the financial incentives are to not do much prevention, to not do the effective management of chronic diseases, which then results in heart attacks, strokes, COPD, pulmonary disease, end-stage renal disease, all kinds of extremely expensive, what we call downstream problems. We won't spend it on the prevention. We won't spend it on the chronic disease management. We spend it on the heart attacks, and we spend it on the strokes.
So you have to change your incentive structure.
You have to change the entire incentive structure, as I said last week, away from the heroic care at the end of life and towards prevention and chronic disease
Okay,
management.
wait a second. Now, doesn't this at least evoke the thought of rationing and the thought of how much health care can we and ought we provide, which gets us into the British model?
Wait,
Jonathan wants to stop me. Go ahead.
Before we get into rationing, and we'll move right into rationing,
ahead.
also just some very specific answers. We spend far more money on biomedical technology in this country. That is, compared to really every other westernized system of medicine, we're overcapitalized. We put much, much more very expensive equipment into our hospitals. And we like it. We make use of it.
And our doctor's offices.
And our doctor's offices. So our doctor's offices are just a sea of technology. The technology is very expensive.
And you're going to pay for it.
Henry Aaron said 25 years ago, the single biggest driver of health inflation in this country is medical technology. Second of all, we pay our doctors more. We pay our doctors substantially more in this country than other countries.
True.
And, so more people making more and more money. The other thing is that we actually spend much more money on branded prescription medication in this country. For funny reasons, we don't know, well, there's political reasons, we don't negotiate rates for branded medication. Now, that said, I will quickly add, we actually spend less money on generic medication. So we have some of the cheapest generic drugs in this world, some of the most expensive branded drugs. So which leads us directly to, how do you get costs down? On a certain sense, exactly what Shoshanna said, what you said, you have to spend less on the technology. We cannot have this many MRI machines and PET scanners and balloon angioplasty units. We cannot be spending this kind of money on technology if we want to get our costs down. The good news is it turns out we could cut a lot of that technology out of the system and not lose any quality. In fact, our quality may actually go up slightly.
Right, because the overuse creates its own problem.
Creates its own problems and is not always the best solution. The most expensive solution is not always the best solution. So if you're a guy who is 75 years old and you're diagnosed with prostate cancer, the thing for you to do is nothing. Okay, because especially if it's a slow-growing prostate cancer.
You're going to die of something else
You're
first.
going to die of something
Thank
else
you.
first.
This is very...
This is not heartening, but
No,
it's
no,
real.
no,
But
okay.
it's real, so why go through a surgery? Yeah. But a lot of us have gotten to the point where we listen to our doctor when they tell us that we need a surgery. However, there have been experiments where people have been actually educated about the risks and benefits of different kinds of approaches to something like prostate cancer. And when they are educated, then they say, hey, I want to go for that watchful waiting.
Except you don't make any money given our current reward system if
exactly
you do
right.
that. Okay,
But,
okay.
but to go back to that word rationing.
Go ahead.
So let me just say it right away.
Go.
Yeah, there is going to be some rationing.
Thank
but
you.
let me explain where the rationing is going to be.
Go
The
ahead.
rationing is not
Ease
going
my
to be
troubled mind.
okay. The rationing is not going to be in the emergency rooms. No
No.
one's going to stop you in any system from getting critical treatment when you have a cardiac infarction. And the rationing is not going to be in trauma care, and the rationing is not going to be in primary care and getting smallpox inoculations for your kid. I mean, all these horrible scenarios, that's not where the rationing is going to be. If anything, we may actually be able to do this better, right? And certainly people who don't have health insurance right now, they're going to have better access to these kinds of services. The rationing will certainly be on elective, high-tech invasive procedures, right? Hip replacements, joint replacements, certain kinds of these things, angioplasties, not angioplasties, but endarterectomies. These kinds of procedures where right now in the United States, you can honestly get in almost the next day or the next week. You walk into your physician and you say, I have terrible back pain. Let's get you in for surgery. I think we got a slot in the OR on Thursday. And that is the norm in this country, right? I've been living with back pain for 6 years, but we can get you into surgery on Thursday.
Nice.
That's not going to happen. In almost every country in the world, the answer is we can get you in 3 months or in 6 months. In that sense, it's rationing. It's true. Well, I guess what I would ask you is, how terrible is that?
Okay. No.
This is not life-threatening.
I want to make two other points.
Go.
We are already rationing medical care.
Right.
We are rationing medical care by ability to pay.
Right.
And we're rationing medical care by where you live. Because quiet as it's kept, there are also parts of this country where there are not enough providers that are available in the rural communities. We forget about those.
And
on
also
the Indian reservations.
Racial, ethnic, and socioeconomic differences
disparities.
as well.
So we are already rationing. So this idea that we're going to go from an unrationed system to a rationed system is a joke. It's a specious idea. The other thing about your back surgery is, you know what? It isn't going to help you. Okay, that's the other piece.
Right.
You're going to get it right away, and it isn't going to help you because the chances are that the thing that will work best for you
is physical
therapy
and rehab.
And learning how to move your body in a way that doesn't hurt your back.
So you've got to figure out ways to include those things into your culture and your incentive system.
And in fact, I'll give you even another statistic. The United States spends by far the most money in the world per day of hospital care. We spend an outrageous amount of money for each 24 hours you spend in the hospital.
Please.
But we also spend fewer days in the hospital than people from any other country. We go into the hospital, we charge you an arm and a leg, and then we throw you out as soon as we can. Who's rationing? If in Sweden I'm allowed to stay in the hospital for 9 days post-op, and in the U.S. I'm allowed to stay in the hospital for 48 hours post-op, what's to say which is rationing? Maybe I'd rather have a couple extra days in the hospital.
Okay. Got to move on. Why, I mean, this is sort of an obvious question to two politically savvy observers. Why haven't we been able to fix the obvious problems within the system?
Because we haven't had the leadership, the genuine leadership. I believe that. I don't think that we've had the leadership. I mean, I sat through the Clinton reform. Yes, I do.
You think that the Obama administration and their allies in Congress really have the ability to make significant change?
Well, let me say one thing. If Ted Kennedy were alive and Tom Daschle were actually the head of the Department of Health and Human Services, then I would bet on the passage of this legislation.
Yeah, but come on.
But comparatively speaking, we have more leadership in this process now than we have in the past, and that's why I think we've gotten further. I don't mean by that a single leader, but I think we've got a lot of people taking a leadership. But there is the other reason is that, as it's said, when you spend $2.3 million a year, trillion, somebody is getting it.
Right.
And the people who are getting it like it.
Right.
So the status quo is very attractive to a lot of powerful interest groups.
$2.3 trillion worth
Yeah,
of
worth of status quo.
Go ahead. How do you fix it?
I wouldn't just. I think leadership is part of it. I think there's an odd confluence of events. I think it's a majority, the Democratic majority in both houses of Congress. It's a very compelling and charismatic leader. It's a certain level of fear of people who've been laid off and are losing their health benefits. So all these things. I would also add to this that the physician community has really changed on this. That for many, many years, for decades, the single most effective and vociferous opponent of health reform was the physician community. The AMA just stood absolutely stock, and they had extraordinary ability to influence legislation. Very, very effective lobbying. The AMA is really no longer the player it once was. Fewer than 45% of all physicians are now members of the AMA, and if you look down at younger physicians, it drops down to below 30%. It simply no longer speaks for them. Second of all, as I said before, there's a lot of doctors out there who are really unhappy. They really don't like the status quo. The people who are making a lot of money, but more and more the people who make a lot of money are doing it on a cash basis. They don't do it on a cash basis anyway. There are an awful lot of physicians who are no longer enjoying the practice of medicine. They're finding it sclerotic, they're finding it bureaucratic, it's obstructive. It's not the profession they train for, and they're open to ideas, and I actually think that's part of the reason why the door is open to an opportunity.
And are you at all sanguine that these opportunities will come to exist, and how do you do that to free them from the trap of their culture?
I think that in the short term, there's still going to be quite a bit of bureaucracy that physicians have to deal with. And I think in the mid and long term, there could be even more, quite frankly, because I think that as we start trying to address the variations in the delivery of care by different physicians, I think there is going to be even more pressure on them to make sure that they're using evidence-based practices and to measure their performance and to give them feedback on their performance.
Yeah, this is excuse me, but this is a huge task. First of all, it's the production of valuable evidence. Then it's the communication to the doctors, the absorption by the doctors, and then the actual implementation by the doctors.
Well, let me give you a statistic that I find fascinating.
Ahead.
It takes 18 years right now between the time when we actually know about an effective practice in medicine to when it is widely adopted in medicine.
That's crazy.
It's absolutely crazy. And so a lot of people are working on what we call translation. Okay, so we're saying we don't just need to produce the biomedical evidence. We need to figure out how to get people to act upon it.
Yep.
And that takes you out of the biomedical sciences and really into the social sciences. And really into a mix
communications.
into communication and into not just communicating to the physicians, but communicating to boards of trustees of hospitals, for example.
And excuse me, and
consumers. But
so.
I'm stuck on the boards of trustees because there was an article just a week ago that in a survey demonstrated that less than half of the hospital boards of trustees see quality of care as one of their primary responsibilities.
My jaw has officially dropped.
Right, less than half. And
what's more than quality besides bucks?
Bucks.
Filling the beds.
Filling the beds and bucks.
Balancing a budget.
Also bucks.
And prestige.
And prestige.
Which means
and
bucks.
Also, right?
Prestige
no,
means fancy
prestige.
procedures, a transplant unit, a cardiac.
And also something named after you.
Oh,
something
wait,
named
stop.
after
That's
you.
too depressing. We don't have enough time. Wait.
And the nursing shortage, maybe, when there is one.
Go ahead, Jonathan. You got whatever you got to say. Say it in 15 seconds. Go ahead.
That's okay.
I'll go.
Well, I just think that that's right. There has to be a culture, and part of the problem is that the people that we are attracting into medicine are very, very smart, but they're not team players. One of the things they value is the professional autonomy.
Sure.
People become doctors because they don't like being part of a large bureaucracy.
That's why people become academics.
And so they get extraordinarily defensive when people start telling them how to practice medicine.
Okay. What's next? We're sitting here in the middle of November of 2009. We've got a House bill. We might have a Senate bill. What do you see next, and what ought it to be? And you've got 45 seconds each to answer that question.
I think that what is going to be critical in the next 2 or 3 months is that as Harry Reid decides what to put out, as we get a filibuster or don't get a filibuster, that there's all that congressional action taking place. What really has to happen for this to come to fruition is for the public at large to make it clear that this is what they want to have happen. The Republicans are right now out there saying, we don't want this to happen. We're actively opposed to it, and people are really making very outrageous statements. I think that those people who really want to support health care reform have to come out from behind their doors and from underneath their blankets and actually start getting active again in the same kind of way we got active in the Obama election.
Okay, Jonathan.
I would agree. A couple of ideas. First of all, I think that's right. The Democrats have to simply get a little more aggressive. Sarah Palin and Betsy McCoy-Ross have been awful. They have just been extraordinarily irresponsible in spreading mistruths, lies. Let's call them lies. They have simply been lying to the public. Their lies, for some reason, are very appealing to a certain segment of the population. They create paranoia. They create panic. And the Democrats have to counter this. They can't just step back. They've got to counter this. My second point would be, I think we've got to get something through.
Right.
And if you've got to give away abortion money, give it away. If you've got to give away the public option, give it away. But do what you must to get something through this fall.
Okay. This has been the second of an extremely interesting two-part conversation on healthcare and healthcare delivery in the United States with my friends and colleagues, Shoshanna Sofaer and Jonathan Engel. Next week, my guest is Harold Holzer, author of a new book, Lincoln, President-Elect, Abraham Lincoln and the Great Secession Winter of 1860 to 1861. Harold is also the curator of the current exhibit at the New York Historical Society, Lincoln in New York. Hello, I'm Doug Musio. Let us know what you think about this show. You can reach us at CUNY.tv. When you get there, click on the bar that says Contact Us and send your email. Whatever it is. Thanks, no thanks, obnoxious, do it. Send it.